All right, so this is our Hesi sample review. This is going to be some basic questions. We're going to call this lecture number 1. I did a quick windshield survey, and it looks like people would rather do like 20 questions, and then that be the brunt of the discussion versus doing, a billion of them. So let's jump into them one by one. We'll also talk about the 7 principles. If you haven't seen the 7 principles video, it's worth a watch. It's going to help you be very successful with these Hesi type questions in order to answer them appropriately. So let's go ahead and go to the next slide and we will get started. So let me get my little pen ready. All right, so a mother runs to the emergency department with a toddler in her arms and tells the nurse that her child got into some cleaning products. That's not good. If the child smells of chemicals on the hands, face, and the front of the child's clothes after ensuring the airway is patent. Let's underline airway is patent. That's important. What action should the nurse implement first? All right, cool. So toddler in her arms, child got into some chemical products. We don't know what that is. Smells of chemicals on hands, face, and on the front of the child's clothes. So AKA, we tried to drink it and then it spilled all on our clothes in the front of our clothes, which is why our hands smell like it, our face smells like it, and the front of the clothes smell like it. All right. So airway is patent, which means we have confirmed that the patient is stable. All right. So now what do we do now that we know that the patient's stable? That's what they're saying. That's what this breaks down to. So this whole paragraph we don't even need. All we need are the following. Child got into some cleaning products. Child smells of chemicals on the hands, face, and the front of the child's clothes. Everybody can picture your kid or your brother or sister, whoever, drinking a big cup of juice that they shouldn't have, and then they just dump it all over the front of them, right? That's what happened with this kid. All right, after ensuring the airway is patent, which means they're stable, what do we do? Call poison control emergency number. The problem I have with this is we are the poison control if they're in the emergency department. See right here? In the emergency department. So it's the nurse's job to do the poison control regimen, and that's cool, but I would go ahead and waste my time on something more important. So determine the type of chemical exposure. Yeah, this is probably going to be our answer. I can tell you this is our answer, and here's why. Because if I call the poison control center, the first thing they're going to ask me is, well, what did they get into? Duh. So that's why B is going to be our answer more than likely. All right, obtain equipment for gastric lavage. I don't know that I need to do gastric lavage. That's a waste of time, right? This is going to follow principle of passive versus active. This is going to follow the principle of one of these things is not like the other, one of these things does not belong. Assess the child for altered sensorium. All right, cool. We can do that. But again, we can do that after the fact that we've figured out what it is. It's a chemical problem because we might have an antidote. We have no idea. We might be able, since these guys are specialists, to get a better answer what that looks like because the doc is going to rely on whatever poison control says. Docs inherently are not familiar with all of that, so they will call poison control, or their practitioner will, or they'll have one of the nurses get on it. So in this instance, we're going to be taking care of the kid, number 1. We're going to find out what the chemical exposure is while you got somebody calling poison control, and then I'm vocerating them and saying, hey, listen, call them vocera, say, hey, listen, it's da-da-da-da-da, it's a chemical. And then they stand by and let us know what we need to do immediately. Sometimes we even 3-way call docs. So it just kind of depends on the situation. But this is why B is the answer, most definitely. And we will look on the next slide to see if I'm right. And yeah, here we go. So B is clearly the answer. Determine the type of the chemical exposure. Again, once we've determined the chemical, poison control should be called, right? If lavage is recommended. Yeah. So these are the rationales. Poison control should be called even if the chemical is unknown. Well, obviously. But we're going to do that once we find out. We need to find out what it is first and then give them a buzz. If lavage is recommended, right, that's going to be something later on. And then altered sensorium, that's going to be issues that are in relation to the ingested chemical, which again, we need to get to the bottom of and find out first. So that's why we're going to do that one. All right, let's do the next question. All right, so look at this question. Which conditions are most likely to respond to treatment with antihistamines? Cool. And then we're going to underline the word conditions as well. and then we're going to underline respond to treatment. Okay, so this is basically what it's asking us to select all that apply. So bronchitis. So bronchitis is inflammation of the bronchioles. We're going to need more than likely an antibiotic for this problem. Antihistamine isn't going to help us with this. So let's knock that one out. Otitis media, again, antibiotics. Contact dermatitis, this one is going to work with antihistamines. And this one definitely is going to work with antihistamines. Allergic rhinitis. Myocarditis, oh boy. So that means something with cardiac and muscle and inflammation of, right? Because we know Latin. So it is the cardiac muscle is inflamed. This is not going to be something the antihistamines are going to be able to do anything about. All right, so usually we're looking, when we're talking about antihistamines, remember we're talking about an IG-mediated response. So without getting too incredibly complicated, we need to make sure that we are properly understanding what matters with the IgA nasal antihistamine secretory response specifically. So those are going to be affected by that antihistamine, and the only things that we have, they're going to represent that mediated response. It's going to be something that's going to calm down that inflammatory process is going to be B and D, final answer. And the rest of it's just too complicated for antihistamines to do anything, or it's just not even indicated. All right, we'll look and see if we're right. Next slide. All right, and we are right. It is allergic rhinitis and contact dermatitis, correct. So again, if you need any help or clarification, I would look up IgA-mediated response. That'll help you out with that. Give it a quick search engine, read about it for a couple minutes and move on. You do need to know this because it is going to come up. I have seen it come up quite often, and you need to know what response it represents as well. All right, next slide. All right, so let's do this question. An older client, let's do older client's daughter calls the home health nurse and reports that the mother has become forgetful, ruh-roh, and is confused at night. Okay, automatically I'm going urinary. Automatically I'm going, have we had a fall, in my head? Because this is where we automatically need to go when we hear older client, forgetful, and confused at night. Just expect it. I'm not even looking down. I have not even read the next sentence, and I can promise you this is where this is going. The daughter states his mother's behavior changed suddenly. Here we go. Is it a UTI? Is it a concussion? Looks like it's an acute situation. Has become very forgetful. So we don't know if it's acute or chronic, but it sounds like it's more acute than anything. A few days ago. Boom. So acute, and is now getting worse. So we have a sudden change in mentation a few days ago. It's getting worse. I'm pretty sure this is UTI. And I haven't even looked at the answer bank. All right, what action should the nurse take? Select all that apply. All right, cool. Ask the mother if she's experiencing any pain with urination. UTI, that's the direction we're going in. I'm going to circle that one. I like that one. Encourage increased intake of high-protein foods. Why? We haven't talked about a wound. That's a no-no. If we're talking about high-protein foods, we're more than likely talking about wound healing and or someone who's post-surgical, bone, titanium, hip type of surgeries or anything that's closely related. Instruct the daughter to check her mother's temperature. Again, UTI. Going right back to it. Boom, I'm going to circle that one. Review the client's current food and medication allergies. Why? What a waste of time. That's a no-no. Yeah, what's that going to do? All it's going to do is delay care. Food and medication allergies have nothing to do with these signs and symptoms. We might need it later, but for right now, we're just trying to figure out what's going on. Determine if the mother has recently experienced a fall. Yeah, see how I talked about head trauma earlier? Because whenever you hear someone's had an acute change, it's only a handful of things. It's either a brain bleed, sudden head trauma from a fall, or UTI, especially when we use this right here, older client. Just expect to go in that direction. All right, so let's see if we're right. I say ACE. In the words of the late great 90s band tag team, whoop, there it is, ACE. Done. All right, let's go to the next one. All right, let's read this one. The nurse is assessing a male with a history of Addison's disease. All right, so Addison's disease, if you don't know it, we need to know what it is. So Addison's disease is a deficiency of cortisol. And what that can lead to, believe it or not, is like a Addison's crisis, which could lower your blood pressure and is potentially life-threatening. So it's pretty serious stuff. Client has flu-like symptoms and nausea. So flu-like symptoms and nausea with vomiting over the past week. That's a big deal. The client's spouse reports that he acted confused. We'll circle confused. Was extremely weak. When he awoke in the morning, the client is febrile. I would expect that for Addison's disease. I'll explain why in a second, and has tachycardia. I'll also explain that one. The healthcare provider diagnoses acute adrenal insufficiency. Yeah, I'd say so. Which medication will most likely be prescribed? All right, whenever you're talking about Addison's disease and we're talking about cortisol, Addison's disease, cortisol. I don't know how to do that one. Let me look at this for a second and see if I can make a hack for Addison's disease and cortisol. I'll come back to this one. I'm going to say we're going to add some cortisol for Addison's disease. C-O-R-T-I-S. Sorry, I'm doing this with the mouse track, not even the mouse pad. Cortisol. All right, cool. So hydrocortisone sounds like cortisol. This is going to be our answer. All there is to it, for sure. Potassium's got nothing to do with it. Insulin has got nothing to do with it. Specific to the symptoms that we're having. Hypertonic saline solution is going to potentiate things getting worse, because if we're hypertonic, we're going to have more solute or more sediment to solution or fluid, and this is going to cause more problems for this patient. So 20 milliequivalents of potassium, that's going to make it worse too. So all of these things make it worse. This is the one thing that's going to make it better because this is the treatment option for it. So one of these things is not like the other. One of these things does not belong. Worse, 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 better. All right, next slide. Let's see if we're right. All right, there we go. We are correct. So we will move on to the next slide and do another question. All right, so a client with a history of mitral valve prolapse. Let's underline that. Is admitted because of a fever. Let's do this. Dyspnea on exertion. This is already going towards endocarditis. I can tell you that. Mitral valve prolapse, endocarditis. There it goes. Acute infective endocarditis. So acute infective endocarditis is something that goes hand in hand with mitral valve prolapse when you're looking at your NCLEX questions. You need to know that the two are correlated. Infectious endocarditis is an inflammation of the endocardium. That's the inner lining of your heart, as well as the valves that separate, all the four chambers within the heart. It's usually caused by bacteria. It's a wide variety of things that cause it, include manifestations and sequelae, which is a big word for I got sick off of something that made me sick. So that's kind of how that works in a nutshell. We also have petechiae of the skin. These are all common signs of this process. So monitor cardiac rhythm via telemetry. We're going to select all that apply according to this. We're most likely going to select this one. A is definitely it. Report changes in pre-existing murmurs. Yeah, that's a big deal because that's also going to be a problem with this endocarditis, right? Schedule rest periods between activities. This dude really shouldn't be doing much of nothing, to be honest. Not for right now while we're trying to figure this out. Maintain record fluid intake and output. If he were congestive heart failure, sure, but not infectious endocarditis. This is something different. Initiate contact transmission precautions. Yeah, you betcha. Right? This is a bacterial infection. We could be spreading this around. If we get this into the bloodstream just right, it could go bad. So let's not do that. And let's check our work. I say A, B, and E. Final answer. And what do they call one of their greatest presidents of the nation? Abraham Lincoln. Yep, got that one. Let's move to the next one. All right, the nurse is planning an educational session for new parents on ways to prevent sudden infant death syndrome. This is already going to go to don't lay them on their belly. Watch this. I haven't even read this. What information is most important to provide to parents of newborns? So let's underline information. So we're educating. Most important to provide to parents of newborns and infants. Bless you, lady. Let's see. Remove pillows and soft toys from the crib at bedtime. We should never have them in the crib, period. Keep a bulb syringe accessible for use for an infant. Okay, principle 6. Can you elaborate? Like, keep a bulb syringe accessible for use for an infant where? Right, you're not giving me all the information I need to clarify. If I have to clarify a statement or question it, it's not good. Position the infant in a supine position while sleeping. What did I tell you guys? See? All these run under patterns. If you're dealing with babies and SIDS, you're always going to be dealing with a position of being supine. Also going to be with having a firm mattress and not having a bunch of blankets and such around them. And then, I don't even need to look at D, but let's do it anyways. Do not prop bottles for an infant during naps and bedtime. That's got more to do with aspiration, not SIDS. I'm going to go with C still, final answer. Because D, do not prop bottles for an infant during naps and bedtime. You shouldn't prop bottles, period. Yeah, period. All right, cool. So C is going to be my final answer. Let's see if we got it right. I'm pretty sure we did. And C is accurate. Let's go to the next question. Okay. The healthcare provider prescribes hang on, I can do this. Methlorgonavine, methlorgonavine maleate. Hang on, let me check it. Methlorgonavine. Let's see how close I am.
Methlorgonavine.
Yes! Score!
Methlorgonavine.
I'll take it. I'll take the victory. All right, cool. So, what is this? Well, you know what? Here's the bottom line. None of this even really truly matters. I mean, it kind of does, but I'll get back to it. Methlorgonavine. All right, cool. For a postpartum client with uterine atony. Okay, cool. This is a lot to unpack. And I'll do this just for the sake of doing it because I actually know what this medication is. And it's kind of a wicked story. All right. What findings should indicate to the nurse to withhold the next dose? All right. Here's what you need to know. You guys are going to see this and freak out and go, I can't do this. Yes, you can. Calm down. Don't look at the med. Look at the patient. Postpartum client. Uterine atony. Okay. So, what would cause a postpartum client to freak me out? Well, there's only one significant issue or another significant issue. And beyond that, there's not a whole heck of a lot in baby land that I can think of that shows up on an exam. And it's either one or the other. You ready for this? Number 1, we get super hypertensive, right? And we go into preeclampsia. And we stroke out. You know how I know that? Because as someone who worked in neuroscience and neurosurgery in that department in a level 1 trauma for like a long time, and like, you know, the neuro PCU and ICU, like there was a lot of times where this would happen, and they were pretty young. They would be in their, I don't know, mid-20s. There'd be the occasional 40-year-old, but it happens, believe it or not, more often than you think. So these people go into preeclampsia, and they're, you know, 1 or 2 day post baby, they can't get that pressure down, and then they have a stroke and end up on my unit. So it's kind of a wicked combination of trying to coordinate baby and mom. So I know that for a fact. Whenever I see postpartum client, why would I need to withhold a medication? Well, if I got hypertension, okay? This medication is actually a derivative that sends a signal to your brain that says you are taking LSD. Sorry, I don't have the cool pen to the mouse pad tablet biz, but it's going to happen because this is annoying and I'm actually using my trackpad on my laptop. I'm not even cool enough to have a mouse because I'm a dork. But all these things are going to change. It's going to get better, I promise you. it's annoying me that I can't do a better job. So we're going to do a better job. Just give me a couple of weeks to figure it all out. So I'm going to go with hypertension based off of all the things that I just said. And I want your brain to go in that direction as well. The other caveat is hemorrhage. So if we're just losing a ton of blood. All right, so hypertension is one of them. All right, difficulty locating the uterine fundus. No, that's just a nurse that doesn't know what they're doing or how to palpate. All right, move. Saturation of more than one pad an hour. Yeah, she's postpartum. I would say that that's potentially normal, especially if we have uterine atony. Now, I almost said atrophy. I want you to think of atrophy as wasting away of muscles and shrinking due to, misuse or no use, right? Now, meet its second cousin, atony, which is weakness. So if I have a weakness of the uterus, I can see where that could cause some difficulty, right? Specific to saturation of more than one pad per hour, potentially, all right? And then here's the principle of, can you elaborate? This is excessive lochia, but it doesn't tell me specifically what that means. I don't know if I got a clot the size of a fist. I don't know if I got the clot the size of a dime. What is excessive to you? What is excessive to me? You guys see how I dress. You know my idea of excessive is definitely different than yours because I'm super conservative at work and yikes. I have a really, really, really dear friend who every single time I do something super stupid, they do the Bill and Ted, yikes, like the whoa. It's that moment. So there was my moment for you. So what is excessive? There's a prime example. So I'm going to go with A, hypertension. Let's see if we're right. Let's go to the next slide. And it looks like, yikes, we got it. So next slide. All right, the pressure is on because we are pretty far into it. Now I'm like, all right, can I really do this? I'm not looking at any of these questions. I'm just talking my way through it because what I'm trying to do is, you guys got to remember, my headspace is super weird. So like, I've already done the headspace that I need to do to teach you what I need to teach you, right? Because I went to school, right? But I want to go back into your headspace, and I want to remember what it's like to be a college student. I am a college student still. Yeah, I get it. It's totally different from nursing, right? Like a philosophy degree or, I don't know, an ALM or things of that nature. That's one entirely different direction, right? Versus, I don't know, being a museum curator, which is entirely alternative, different direction in that degree, right? Versus straight up archaeology, whole different direction that way. We're over in Indiana Jones land. So when it comes to medicine, it's a lifestyle. It's not even a degree. It's a lifestyle. Your whole entire existence is going to change, and you're not going to be able to get out of it. Dude, you're taking the red pill. You've sucked it down. You've drank some Woda in between. That bad boy has digested. There ain't no coming back from it. I'm so sorry. Welcome to the family. So that being said, there's going to be a lot. So let's look at this game over here. This next question. The nurse notes that an older adult client has a moist cough that increases in severity during and after meals. All right, stop. I'm so glad I don't look at these. The first thing I think of when I think of people who have a moist cough, let's underline that, moist cough. Why is this bad? Because I'm hearing, if it's moist, I know people hate that word. I don't understand why. I don't understand a lot of things, but specifically that. If you hear a moist cough, you go, uh-oh, that's in the lungs. You know that sound, right? It sounds like the sound of somebody blowing in a straw into chocolate milk. And I'm looking around for a straw because you guys know that I'm weird. But that's what it sounds like. And you know immediately, oh boy, we're in trouble. So let's see. Based on this finding, which action should the nurse take? All right, cool. So I'm thinking moist cough. I'm thinking aspiration. Something's in the lungs. And then if you notice this, it says in severity, it increases during and after meals. Wow, wow, wow. Boom. So this is aspiration. So when we're dealing with aspiration, we got to do a couple of things. We got to make them NPO, right? If you ever get a question about that, automatically make them NPO. You have to have a consult with speech therapy because they have to potentially do a glide on them to see if it actually is opening and closing. And by it, I mean the epiglottis, little flap. All right. You have to immediately, sit them at a 90-degree angle. You need to listen to the lungs, potentiate a chest x-ray. Okay. Keep your brain kind of in this rationale. The lungs get messed up. We don't know how bad, that kind of a deal. All right, let's look at our answers. Collect a sputum specimen immediately. Well, no, because we're going to do a sputum specimen when it's bubbling and brewing. And right now we just have a moist cough. But a moist cough doesn't necessarily mean that we have foamy, frothy type of anything. We don't really know what this moist cough means, so we need to just kick back for a second. It doesn't say he's febrile, right? Doesn't say, we're getting an indicator for being sicker. All we're saying is we got a cough at this point, so I'm going to let that one go. I don't like that one. All right. Request a consultation, to confirm dysphagia. Yeah, this is going to be speech therapy, or what we call ST in the neuro world. I like that one. By the way, if you ever get around a speech therapist, do not treat them any type of way, because I don't know what it is about PT, OT, and ST. That's physical therapy, occupational therapy, and speech therapy. I don't know why nurses treat these guys like they just don't even exist. Let me tell you what. Those three guys will bend over backwards for you if you ever need them. And on a neuro unit, you need speech quick. And if speech likes you, speech is going to go to your room first and take care of your patient first. And you're going to have the best patient care. And your surveys are going to look the best. And then you're going to piss off everyone else around you. And you're going to go, oh boy, what do I do? Do I lay back and, remember where I come from? Or do I raise the bar? But remember, when you have that opportunity to make that decision, do what I did when I started teaching here. Look around at who it's affecting. Look at the students. Look at your patients. It's the same deal. See how they're affected. Listen to their words. If you hear something more than 10 times, it's a problem. You got to take that problem somewhere with it. So, in the year that I've been here, a lot of things have changed, and I'm quite grateful for it. And it's because we're watching our patients, quote unquote, aka you guys. So make sure that we're watching them in kind, because that's how we actually have inclusive change for the better. That's actual, not just a bunch of, bumping gums saying such, but not really doing much. So keep letting us know how we're doing. We want to know. We want to be there for you. I can't say this enough. A couple of you are doing an eye roll. Y'all know better than that. Y'all have seen me. Keep watching me. All right? So what else we got? Offer the client additional clear liquids frequently. Psych! Okay, I'm not even doing that. If anyone needs to know why, send me a text. Don't do it on the WhatsApp. How about that? Just send me a personal text and I'll explain why I just chuckled. All right. Encourage the client to do deep breathing exercises daily. Well, that's not going to fix the problem. We got to figure out what the problem is. So I'm going to say B, final answer. Also, one of these things is not like the other. One of these things does not belong. Requesting a consult to confirm dysphagia is completely different from these benign things. Also, active versus passive. Collecting a sputum specimen immediately, that sounds like it's an active action. But is it going to create a delay in care? Well, yeah, because we're going to be waiting around for a sputum when we could just get a consultation to confirm that they have dysphagia. See why that's passive and this is active? All right, I hope that helped. Let's do the next slide. Awesome. All right. Done it again. Let's go to the next one. Oh boy, I don't know if I have the strength. Okay, so everyone's favorite type of question. Boy, guys, we're going straight into like OB land. I'm dizzy. Is anybody else dizzy? Oh, there's a baby involved. Yeah, we're in OB land. Oh boy. Where's the yellow brick road? That's where I feel. Where are the flying monkeys? I feel like a flying monkey right now. Okay. So a multi-Paris client. Let's go ahead and underline that. And luckily I know Latin, thank God, because multi means many And Paris means, loosely translated, given or having given many births. Okay. Client who delivered her infant 3 hours ago. Yikes. That's like Gilligan's Island, a 3-hour tour. One of you people might know what I'm talking about. It doesn't matter. It's fine. Ask the nurse if she can take a warm sitz bath. Okay, cool, because that's normal. Because it helped reduce perineal pain after her last delivery. Cool. What action should the nurse implement? All right. I think I can. Okay. I love trains. All right. Using an analgesic spray to the perineal area to reduce pain. Let me read this again. Didn't say she was torn. Analgesic spray. It's numbing. I hate this game. Listen, I told you I'm going to do this live because I'm just as stressed as you are. Like, I need for you to know that I feel what you guys feel because, like, this is pretty new to me too. And I need to challenge myself to get more familiarized with these if I'm going to sit here and teach you guys how to get through them. All right, cool. Apply an ice pack to the perineum for the first 24 hours. I know that's a thing. Teach the client how to practice Kegel exercises. Pfft, whatever. That ain't got nothing to do with nothing. Right? Because we're talking about to help reduce perineal pain. Kegels has got to do with something completely different. So we're going to get rid of the musculature of things. Review the use of sitz bath equipment with the client. No. Wait, how? 3 hours ago? No. Back up the train. Listen, 3 hours ago. I wasn't joking about the Gilligan's Island thing. That was real. Here's why. Do we really want to put anything on it 3 hours post? Right? Like, isn't that a thing? Hear me out, guys. Review the sitz bath equipment. All right, this is good. Here's why this is good, because I'm actually going to be using my own 7 principles to answer my own question that I'm completely oblivious about, even though it's probably a very easy answer. I'm leaning towards B, if I'm honest. All right, let me use the principles. I'm really struggling on this one. Why am I struggling on this one so hard? Because it's psyching me out. Because it's OB. So this is passive versus active. An analgesic spray to the perineal area 3 hours post-birth is going to burn like crazy, right? Like, that's going to burn like crazy. So while this is good, and this is technically an active action, this is going to be passive because this is going to delay the care and the reduction of pain for the patient. This is going to create more pain. Teaching a client how to practice Kegel exercises isn't going to have anything to do with the area. Plus, I can argue that it's going to stretch those areas, which is going to produce more pain. Reviewing the use of sitz bath equipment with the client, that's going to delay what we need to do to fix the problem. And should we be using a sitz bath 3 hours after? I feel like that would be an infectious process problem, but I'm not entirely sure. But I'm willing to bet on it. I'm willing to make a small wager. So again, I'm gonna go with B, based off of the principle of active versus passive. The only active action that's going to give immediate relief is throwing ice on it. Analgesic spray, it's going to burn. Yeah, B, final answer. I'm going to use my own principles to answer this problem, yo. I hope I'm right. We'll see you next slide. And the crowd, go, go, goes. Wow, wow, wow. That's how I feel right now. Because I answered no big question. Professor Scott would be so excited right now. All right, next slide, guys. Man, not only do I feel like I have just given birth to a baby by answering that question about giving birth to a baby, ironically enough, but now I've gone back into the land of neuro and I'm finally at peace again. It's like I've slipped into the middle of a Doctor Strange movie and I get it, and I'm wondering why everyone's confused, and I'm like, wow, we're finally in my head. This is fun, right? So we're going to go back into my world, and I'm super excited because now everything is copacetic. So, the wife of a newly diagnosed. Let's look at newly diagnosed. Client with Parkinson's disease. Yikes. Ask the nurse for an alternative or complementary medical therapy. I already know where this is going. I haven't even finished the sentence. Ugh, I hate this trackpad. Might cure the disease. Cure. All right, which response should the nurse provide? The response, and I'm not even looking at the question bank, is to let them know there is no cure. Because for Parkinson's disease, the best that we can do is slow it down. And what we do to slow it down is we essentially shut down the brain. So this is a matter of excitability. And when you're dealing with a matter of excitability, you have to shut it down by grounding it. And you ground it through way of chemical grounding. Okay? It's more complicated than that. There's ions and this is and that's involved. But that's the general, all you need to know about how that works right this second. I'm trying to taper it down real slow. All right. So it's a very significant firing. And it's neurodegenerative and uber progressive in symptoms and quite jarring on a lot of different levels. So when you have a newly diagnosed patient with Parkinson's disease, they are going to automatically go to a very scary place very quickly. And they are going to try to bargain by way of alternative or complementary therapies. Remember, I've seen some of these therapies doing what I do. I see them and I see some of these therapies get worse. They actually make the patient worse. And I've got to fix them to get them back to baseline. I've seen patients who take in some of these alternative or complementary therapies to take care of their Parkinson's, and it killed them. I'm not going to get into it, but just know that just because you're putting something in your body, and just because, it says it fits this so-and-so and such that came from such and such book and such school who says such and such is the way to do this, that's not smart. Don't do that. I see a lot of that. Incidentally, I've also seen a lot of people who put street beauty products into their skin, and then they get really, really sick and it goes to their brain. So people that are doing this Botox, it's coming from some other country and it's a cement derivative, those people too. They end up on the unit as well. It's kind of bizarre. So all right, cool. That's probably where we're gonna go with this answer. If I had to be a betting person, so let's see. Complete a list of alternative medications that are effective in curing Parkinson's disease. Why, Lord? Why? No. Again, there is no cure for Parkinson's. It's progressive. It's neurodegenerative. It's miserable. It's sad to watch somebody go through it. They basically turn from super excitable with a stone face. And just the act of eating is embarrassing. I had a patient when I was in my primary care rotation, and I was in Mount Vernon, Ohio, had the coolest, literally the dopest instructor ever. Just the coolest guy ever. He was a PA. and he ran the house over there on his end. And my patient came in because he was embarrassed because he had shaken and he couldn't go eat, and he hadn't gone out to eat with friends in about 5 years. And I remember looking at this person and going, "Hey Kev, real quick, you got to come get this guy. This guy needs, he needs L-Dopa like right now, 5 minutes ago." And he said, "Huh?" And I said, "Dude, this is my champ. This is my guy. He's over here trying to go eat and he can't eat. So he's really thin. He's cacaxic basically because he's emaciated because he can't eat because he can't hold nothing. He can't hold a fork to eat peas. He can't eat a spoon to eat peas, right? Like, so he doesn't want to go out with his friends, and then he gets depressed, and then he's like, why even care about eating at all, right?" So we got this guy on L-Dopa, and I saw him 6 weeks later, and it was like a whole nother person. Like a whole nother person. This is how important this medication is, all right? This is how important it is to not mess with that infrastructure by way of alternative or complementary therapies. This is why we have to talk to our patients this way. So, explain that there are no conventional alternative or complementary therapies to cure Parkinson's. Listen, I've been saying it this whole time, and I'm just now reading this. Encourages the wife to vent her feelings, is what it's supposed to say. There you go. Encourage the wife to vent her feelings about having a husband with Parkinson's disease. Jesus, no, I'm not getting into that. Shiva, all of the other creators, no, I'm not getting it. I'm not doing that. That's not happening today. No. Tell the wife that her husband's neurologist just would know more about alternative treatments to cure Parkinson's. No, don't push this over to the neurologist. Keep this out of my bay, friends. No, stay out of my department. Don't do that. Any doc, any nurse practitioner, any nurse is going to know that there's no cure for this. And whether you want to be the person to say it or not, toss it to your doc. You're a nurse. This is the fun thing where docs always toss things to nurses. Cool. Toss it back. Pass the woe. Oh my God, there's like 3 people that are like, what? Pass the woe to the doc and be done. Be like, "Doc, I'm passing the woe." Right? Catch it. You better make it stylish. All right, next slide. And yeah, just like I said, I don't even think I even told you what my answer was for sure. I usually round back over to my answer. I didn't even do it this time because I was pretty convinced of it. Remember, when you're talking about Parkinson's, you're always going to deal with L-Dopa. It's always going to be a thing. They call it Simonet sometimes. So make sure that you are familiar with what that means. Make sure that you understand what's happening in the brain as it happens. Make sure that you understand that they have to march in place whenever you get them up first thing in the morning. Sometimes that pops up in question form. I'm trying to think. The biggest deal is medication, making sure that they take it at the same time every time. They always talk about a mask face, and they're always going to talk about tremoring. So those are the best things that I can tell you for those. And then I'm going to stop right there because this is 43 minutes long, and then I'm just going to keep going until I don't want to do it anymore. So we will resume this with our number 2 lecture. I love you guys. I'm proud of you, and I will see you hopefully the next time around.